Started. Looks like we have a quorum. Good morning, everyone. All right, next up in the Morning Brew series is strokes. Something that's probably all too familiar to most of you here. Probably have known someone that has had a stroke or at least heard of somebody. So very common issue. All right. So what is a stroke? Bottom line is it is an interruption of brain flow to the brain tissue, just like a heart attack. This is a brain attack. So you don't have the oxygenated blood getting to the tissue where it needs to be, and then in the setting of stroke, that can be one of essentially two ways. You can have an ischemic stroke where a clot or some atherosclerotic plaque breaks off and goes down into a vessel small enough to where it can plug, and wherever that vessel is plugged, then everything beyond it doesn't get any blood because it's plugged. The other way is a hemorrhage, where if you have hypertension and you have a little weak spot in your blood vessel, that blood vessel can then burst and then bleed into your brain. And if the blood isn't within the blood vessel, it's not going to be able to perfuse the brain. That blood outside of the blood vessel is going to cause pressure. It's going to kill brain tissue. So those are the two ways you can have a stroke. Most common being an embolic or a clot stroke. That's 87% of the time you're going to have a blockage and not a burst aneurysm. That's only 13% of the time. But the management of those two things is vastly different, so that's why we always CT scan your head. And we'll go into that in more detail here in a second. But nonetheless, early recognition is essential, because just like heart tissue, time, and in a heart attack, time is tissue. Time is cardiac tissue, time is brain tissue. The more time it is without its oxygen, good morning, the more damage that's going to occur. So early identification and intervention is absolutely key. Obviously, a true medical emergency, disability and death reduced if we respond quickly enough. All right. Leading cause of adult disability. So significant. You generally don't die from strokes. You have severe disability from strokes, and you go on living. So, again, to reiterate, leading cause of disability. Let's see. Every 40 seconds, someone in the U.S. has a stroke. We've had a lot of recent strokes here in the area recently. So it happens a lot. And why is it happening a lot? Most of the time it's because of atrial fibrillation. So that pathophysiology explains a lot. So when you have atrial fibrillation, the top chamber of the heart is not pumping rhythmically, it's quivering. When blood is agitated or quivered like that, it tends to clot. So that's why when you have atrial fibrillation, not only do we try to control your heart rate, but we anticoagulate you with Coumadin or Eliquis, dabigatran, whatever the anticoagulant of choice at that time is. We prevent your blood from clotting, thus thereby preventing you from having a stroke. Especially on Coumadin, when you're not in that therapeutic range, which is very difficult for some people to maintain, and you fall low, so your blood becomes more coagulable, you can then develop a clot and have a stroke. So the atrial fibrillation, 5 times greater risk of stroke. This is by far the biggest offender that we have, is inadequately anticoagulated atrial fibrillation. There are certainly other issues: hardening of the arteries, atherosclerosis, blood clotting disorders, all this sort of esoteric stuff. But the bottom line is, most of the time it's a blockage. Most of the time that blockage occurs because of a clot formed because of atrial fibrillation. So if you have atrial fibrillation, important to get identified and appropriately anticoagulate and make sure that that is spot on at all times. Because again, you live with this. Dying of a heart attack on the golf course, it's sad for everybody left, but hey, you did what you died doing what you love. With a stroke, which is the same pathophysiology, you don't die. Rarely are strokes severe enough to kill a person. They leave severe disability. So these have got to be, we've got to do whatever we can to prevent this. All right, 2 million brain cells die every minute. We have a gazillion brain cells. So you can lose a few, but you can't lose many. So act fast. And then obviously as we get older, it becomes more common. Because of hardening of the arteries, because of development of AFib, it's a factor as we age. Okay, I already went over this. 2 types of stroke, ischemic and hemorrhagic. So either a blocked artery or a bleeding artery into the brain. And then you have the subarachnoid hemorrhage, which is just sort of a subset of hemorrhagic stroke, treated differently because of the anatomical location. We're not going to go into detail. Suffice it to say 2 main things. It's either blocked or it's bleeding in the wrong place. And then wherever that blockage is, everything beyond it is going to be affected. And everything within that bleeding area that's not getting blood and that is being compressed by the blood that's outside the blood vessel is going to die. And so, hence the severity of strokes, the TIAs, the mini strokes and whatnot. If you have a small clot and it travels out to the most distal artery, you could have very minimal symptoms. Maybe a little bit of blurry vision, maybe nothing profound, maybe a little bit of a headache. Versus something that's way down in the larger arteries, it's going to block the whole left side of your body. You're not going to be able to move the left side of your body. That's a big stroke. So it's going to depend on how big it is and where it's at. And again, immediate medical attention to prevent brain injury or further brain injury. Any questions on the 2 main types of stroke? Okay, and then we have this other thing, this transient ischemic attack, which is like a huge red flag being waved in the air that something is wrong. And these transient ischemic attacks occur when we develop a clot. These are always ischemic. Transient ischemic attacks, hence the definition in the name, you don't have a transient hemorrhagic attack. If you bleed, it's not transient. It's going to develop and evolve. So transient ischemic attack is when you have a small clot, and within our blood, within our system, our physiology, we have natural ways of breaking up clots. We're always forming clots and breaking clots in our normal day-to-day. It's when the system gets overwhelmed and the clotting factors overwhelm the anticoagulant factors that we get into problems. So a transient ischemic attack is when we have small clots that cause a blockage for a short period of time, and then our own body's anticoagulants come down and break it down. This is basically a warning that you've got an area that is either blocked, thinned by atherosclerosis, or you're developing clots that are then showering to your brain. This needs to be addressed. This is essentially a warning sign that you are going to have a full-on stroke at some point. You need to get this evaluated and be anticoagulated. Just because it's transient, that's good. It comes and it goes away within the hour or hours, but it is a sign of things to come. All right, so this is a harbinger of what is in your future. So these need to be taken very seriously and treated as such. You're going to go to the emergency room for a transient ischemic attack just like you would a stroke, because hopefully you're responding to a transient ischemic attack early. Because if it is a stroke, there's more that you can do to save that brain tissue. So whenever you're having symptoms, 911 early. And I think that is the next slide of what are these symptoms that we have to worry about. Covered all that. Okay, so this Be Fast is something you guys need to remember. I'm not going to quiz you on it afterwards, but this acronym is something that should be burned into your brain. Because if you have any of these signs or symptoms, you should immediately start thinking, okay, is this a stroke? And if it is, I need to get somewhere now to get intervened. So what does this all stand for? Be Fast. B is for balance. Maybe your sudden loss of, maybe your dizziness, maybe you're feeling faint, some factor in balance. Eyes, blurry vision, double vision, loss of vision. Face, obviously the classic facial droop. That's very easy to see, and we have a video that's going to kind of demonstrate that. Arm weakness or numbness, in addition to leg weakness or numbness. Speech slurred or strange, sort of tangential, inappropriate, speaking words that don't make sense in the conversation. And then at that point, you call 911. Err on the side of caution when it comes to stroke, because we only have 4.5 hours. And we'll go into why that is in the coming slide. But you really only have, for an ischemic stroke, you really only have a window of 4.5 hours from the last time you were seen well to qualify for clot-busting drugs. All right, and I'll explain why that is here in a second. The thing that I see and that we see in the emergency department so often is that the subtle things, the dizziness, the just not feeling right, the sort of maybe some word-finding difficulties, the subtle symptoms in this BFAST acronym that you're like, is it something? Is it something? And then you wait an hour, maybe it gets worse, and you're like, you're kind of trying to talk yourself out of it. Well, all the while, time is ticking away, and that 4.5 hour window is disappearing. And so this was going to demonstrate the obvious thing that happens, and you call 911 and they get you to the hospital and you get to a stroke center within 4.5 hours. They give you clot-busting drugs, and at the end of that video, he recovers completely. It's when you have the small ones that you wait, or you sleep on it. You start having symptoms at night. You're like, kind of subtle, and then you wake up in the morning and the symptoms are obviously worse. Well, that window is well gone. And then if you just kind of put it off long enough where you're concerned, but maybe it takes somebody else to convince you to go, if you're out of the 4.5 hour window, all we can do is sit and watch and wait, and control your blood pressure and hope for the best. You cannot get clot-busting drugs. And the reason for that, well, we'll go to that in a second. So what happens if you see somebody having a stroke, or if you're having a stroke, what happens? Somebody calls 911, you're going to come into the emergency department, and they're going to do a neurologic exam and see what sort of deficits you have. And then you're going to immediately go to imaging, because we need to find out within that 4.5 hour window, is this a bleed or is this a clot? Because if it's a clot, we're going to give you clot-busting drugs and prevent your blood from clotting. If we do that and you have a bleed, we're just going to make the bleed worse. So we got to determine, what are we dealing with? Do we need to stop a bleed, or do we need to make your blood more thin so that we can get past this blocked area? So you're going to go to imaging immediately. We're going to initiate a telestroke from here. So as soon as we get a stroke alert, it goes off. Whenever we get a 911 call here locally, on all our pagers and phones, we get a stroke alert. So all of the hospital staff, no matter what time of day that needs to be here, lab, imaging, the providers, the nurses, everybody gets a page that there's a stroke alert. So we're immediately keyed up that there's an ambulance coming in, there's a stroke alert. We get a telestroke consult from Swedish, so we get a neurologist on the line who's there and can observe the patient or whoever's in the emergency department with us while we're evaluating, and kind of help guide the care. And then generally, after all is said and done, we will fly you to Swedish, which is the main stroke center, and they will take you from there. But nonetheless, immediately, this is something we take very, very seriously, and so immediately when there's something goes out, even at the 911 level, everybody here at the hospital is alerted, so we're ready to go. You're going to get a bunch of blood tests, obviously, whenever you come to the ED. You're going to get some blood tests, and then they're going to determine what they need to do and start initiating the treatment. Let's talk about the treatment. Okay, so why this 4.5 hour window? So if you have a clot and tissue beyond that is not getting blood and is essentially dying, the theory is, and this window has gone from 2.5 to 3 to now 4.5 hours. The theory is that if that dead tissue, or rather that tissue that is beyond that clot that is dying, is now no longer structurally intact, and that blockage is preventing a fairly high pressure system from getting into that structurally compromised area. If we break that clot and pull out that plug, we're going to cause a hemorrhagic stroke, because it's just going to blow out into tissue that's no longer viable. It's just going to bleed. The blood vessel is structurally not intact, so it's just going to bleed everywhere. So that's why that 4.5 hour window. We got to get there, because we figure that that's a safe enough time to where we can break that clot open, and the tissue beyond it is going to be able to handle being reperfused with blood. So TNCase, or TPA, tissue plasminogen activator, are the two clot busting drugs that we use. We use TNK here. TNK is an engineered version of TPA, which lasts longer, only takes one shot, much easier to use. So if we get the go-ahead from the stroke center at Swedish, the time window is agreed upon, there's a definite moment of last seen well, and that is within 4.5 hours. They have a negative bleed, or they have a CT of the head that's negative for any bleeding. Give the clot busting drugs, fly them out. Everybody's going to fly out and go to the stroke center regardless. Some patients with large vessel strokes, if the clot is deep enough down, or not deep enough down, but early enough in the system where the vessels are still fairly large, you can go in there with a catheter and grab it and take that clot out. But once it starts branching off and getting too small, they can't go in there with a wire and grab it. So if it's big enough, and you're going to have major symptoms, if it's big enough for a thrombectomy, you're going to have complete right or left-sided paralysis, then they're not going to want to do a clot-busting drug. They're going to want to say, hey, let's go in there, grab that, and then we'll give you clot-busting drugs, because they don't want to deal with thin blood while they're trying to take that out. So that's why we consult neurology and neurosurgery. Do not wait to see if symptoms improve. This is that thing. I mean, everybody's real hesitant to go to the ER, and as well you should be. It's expensive. It's a pain. You spend all day there, although ours is very efficient. But that's kind of a big decision to make, especially if you have to call an ambulance. That's an even bigger decision, because the dollar, you're like, oh God, how much is this going to cost? And so you're hemming and hawing, and maybe this will just go away. Maybe I'll take a Tylenol or an Excedrin and wait and see. I'll wait for a few hours. The thing is, you got to err on the side of caution. And we certainly see plenty of patients who come in here with migraines or maybe Bell's palsy, and we work them up as if they were a stroke and rule that out, because we have to. But certainly better to err on the side of caution and prevent severe disability versus coming in and getting evaluated and having that copay to pay, because most of us here have the insurance to at least get evaluated in the emergency department. And then again, calling EMS activates the stroke team immediately. Like I said, you call 911. We here at the hospital, I get a text wherever I am that we have a stroke alert. Time to move quickly. All right, how can it affect daily life? A whole myriad ways. Again, it depends on where in the brain this is affected. But speech, you can see all of these issues are pretty significant. They affect your activities of daily living, activities of daily life. And so, obviously, depression and emotional changes are going to come along with any of these permanent disabilities. But this is a big deal. So we want to do what we can to prevent that. So how are we going to do that? Or actually, what are the main risk factors? All the classics: blood pressure, diabetes, smoking, cholesterol, and of course, atrial fibrillation. You can't really see this, but this is a sort of a risk factor calculator. I'll read through some of these. Is your blood pressure greater than 120/80? That's certainly what we're going for goal. We can debate what the ideal blood pressure is, but certainly if you've had a stroke, that's certainly maybe where you're aimed. Have you been diagnosed with AFib? Do you have diabetes, body mass index, total cholesterol, et cetera? Do you exercise? All of this stuff we're talking about in whole full plate living program. Lifestyle. Very important. Hypertension, most important controllable risk factor. Take your blood pressure medicine if you are prescribed it. Maintain physical activity. Make sure you're using your legs. Limit the salt and processed foods. This stuff that I beat into you every talk that we have. So you've certainly gotten that talk before. Again, more of the same. Do all the good things. Don't listen to rock and roll. Don't smoke. Go to church. Have friends. You'll live longer that way. Okay, so let's do an interactive case here. So 72-year-old guy develops slurred speech at breakfast. Symptoms improve after 15 minutes. Oh, great. Would you still call 911? I had this to where it kind of didn't give you the answer right away, and it kind of faded in so I could quiz you, but you have the answer. Yes, of course. Yes, you call 911. This is a TIA. This could be, that TIA could be something that doesn't occur again for months or years, or it could be something that's a warning to something that's going to occur in the next hour, and you're going to have a major stroke. So obviously, get to the hospital, get evaluated, get on anticoagulation. let's see. Pretty straightforward. Okay, and then again, this Be Fast is really what I want you to remember. You can always call the nursing line. You can call us here. The nurses will answer. They will triage you. They will err on the side of caution every time. If you're having anything concerning for stroke symptoms, they're going to have you come in, and we're going to evaluate you for that. So, but err on the side of caution when it comes to these symptoms. All right, good. That's it. What questions do you guys have on strokes?
If you come in, I come in, and I think I'm having a stroke, and they send me to one of you people.
Mm-hmm.
Do you medicate me right then, or do you wait?
For clot busting, yeah. If you are within the window, you have a clot that's not eligible for them to go in and grab with a wire, then yes, you will be treated here. We will initiate that treatment here, and then we will fly you to somewhere else and get you definitive treatment. We won't just treat you and sit on you and wait.
So you can diagnose this problem?
Yes, absolutely. Absolutely. Sorry, go ahead.
It seems to me like some of these symptoms are also mimicked in some other things.
Absolutely.
So how do we know kind of what you're dealing with? And I guess secondly, is this part of the reason why if you have a fall after you're 65 or older, they automatically do a CT scan to see? Because I was reading something, you never know,
Yeah.
and it said that the blood vessels are actually thinning as you get older.
That's right.
And therefore, it's more likely that you can have a bleed.
Right.
And you can, even if you don't hit your head in the fall, you might still be causing a bleed.
Right. Yeah, so that is true. That's very true. So that's most commonly that's a subdural hematoma. So subarachnoid is deep to the subdural. And that happens because as we age, our brain shrinks a little bit. It's called age-related brain atrophy from blood vessel disease. It just shrinks a bit. But there's blood vessels that come from the cranium, the skull, that dive into your brain. And as the brain shrinks, those vessels kind of get taut and they're suspended. And there's obviously fluid in there. But if you're on blood thinners and your brain is shrunk and those vessels are, and your brain is kind of, you can imagine it being suspended on those blood vessels. If you fall and hit your head and you have your brain shaking a little bit, it will break those blood vessels and you'll get a bleed on top of your brain. And that is not necessarily a stroke. It's a brain bleed and can cause brain damage, but it's not within the brain tissue. It compresses the brain tissue, but it's not within the brain tissue itself. So it's a different type of bleed, not necessarily a cerebrovascular accident, because it doesn't cause the same symptoms as stroke. But yes, the bottom line is your blood vessels thin, your brain shrinks. If you're on a blood thinner, it's obviously difficult for you to clot, so you are at increased risk. So every time you fall, you're over the age of 65, you're going to get a CT scan. Absolutely. Every time. Yep. Because you'd be surprised how many times you find those for minor injuries.
What about the symptoms that are kind of mimicked?
Yeah.
Even dementia particularly, I mean, some of those symptoms,
Totally.
dealing with it.
Yeah, and so, again, that's a tough one. If they have migraines and it's sort of a classic presentation, well, then you can maybe chalk it up to migraines. If this is something, and then the dementia, I mean, they've got somewhat of a progression. If you can't chalk it up to this is what I've seen before, this is something that I'm familiar with. If you can't hang your hat on something and you're at all concerned that this could be some sort of a brain injury, you got to come in. I mean, the mimics are tough. Bell's palsy is a tough one too, because everybody thinks they're having a stroke, but that's a little bit more complex than we want to get into here. But the mimics that's how you err on the side of caution, because you don't know. You just don't know, especially for these subtle, small strokes.
First of all, aspirin therapy, motorcycle incidents, and number two, Watchman.
So the first question is, what do I think about aspirin therapy with motorcycle incidents? I got to be careful, right? Are you at increased risk of bleeding on chronic aspirin if you get in a motorcycle wreck? Yes. Not as much as you would be if you were on Plavix or Eliquis or Coumadin, but yes, if you were on an aspirin, baby or otherwise.
So what's your recommendation? Stay off a motorcycle?
I think you ride really safe. You ride really safe. You wear a helmet. I mean, you can't walk around in a pillow suit all the time, but nonetheless, yeah, I mean that's a risk. That's a risk. Watchman. Okay, yeah. So if you have atrial fibrillation, there's something called the Watchman device. And if you have atrial fibrillation, there's an appendage that hangs off of the atrium, and that is generally where these clots form in the setting of atrial fibrillation that then go into the system and shower into your brain. It's on the left atrial appendage, so it's after it's gone through the lungs, it's coming back into your heart to be distributed to the system. The Watchman device is a device that they place in that appendage to basically take it out of play for any blood to be in there and clotting, and thereby reduces your risk of forming a clot. For people that can't be on an anticoagulant, it does not preclude you from being on an anticoagulant. It reduces your risk if you're difficult to control on an anticoagulant. But if you can't be on an anticoagulant, it's a risk reducer to take out that appendage and eliminate some of the risk of developing a clot with atrial fibrillation. So, good question. What else? Yeah.
After you have a stroke and a lot of those cells are damaged or killed or die, does the brain heal itself, or does that regenerate, or is it just that area dead forever? What's the status?
Some of that area is dead forever. The central core is dead forever. The periphery, as you kind of go out, depending on how much time has gone by since you reperfused, you can get some of that back over time. You can learn those skills. There can be other pieces or parts of the brain that can take up some of those old skills, and you can relearn them. But with the brain tissue that is without blood supply, without oxygenated blood for over however many hours, and we don't really know what that is yet, but that is dead tissue. That does not come back. Yeah, but the shocked tissue on the outside, you can get some of that back. What else? Yep.
And after the 4.5 hours, if you go beyond that, and the clot's still there, then it's just a wait and see type thing? You can't do anything about it.
Right. Yeah, if we were to send you to an academic center, I mean, there are studies pushing that out to 12 hours. Maybe that'll extend at some point, but right now, the risk of you having worse symptoms by blowing the clot and then bleeding into a larger area of the brain outweighs the risk of that outweighs the benefit of trying to bust that clot. Yeah. So yeah, it's just watchful waiting and hoping for the best. Yeah. Nada más? Okay, cool. Thank you all for coming. Appreciate it.